I'm supposed to introduce this session on revisions by talking about femoral bone deficiency in revision hip replacement and how we should classify and how does this classification help us dictate the choice of stems. So what causes the bone loss in revision hip replacement? So we've all seen this type of x-rays. In the old days, they thought it was cement disease, some allergy to the cement. But we all know better now. This is because of the debris generated by the wear surfaces, the polyethylene, and then inciting an inflammatory response. And the inflammatory response then destroys the bone. So we get problems with bone loss. We get these ballooned out lesions that look like tumor-like lesions. And when we go in, we find these macrophage-ridden osteolytic zones. We can also get bone loss from mechanical disruption. So if you have a stem that is not well ingrown, and then of course it starts to torque and subside and turn as we walk under load, then of course you can also generate femoral bone loss. So the principles of femoral reconstruction basically is you have to decide where your good bone is. You decide where your good bone is, and you're going to aim to anchor your new stem in the good bone and go for rigid initial fixation so that you can then get adequate ingrowth of the stem for long-term biologic fixation. And the commonly, most widely used system nowadays is the Paprosky classification. And it has proven itself to be useful both as a descriptive classification, describing where the bone loss is, as well as a way to help us decide how we should pick our choice of stems to anchor the implant. And it is type 1 to 4. Type 1 is basically the metaphysis, the proximal femur, is still well preserved. And there should be no problem to revising this with a standard total hip implant. And this would be a case like we're perhaps revising an ASR implant, resurfacing hip implant, and you saw off the neck and the proximal femur remains good. The type 2 will be the proximal femur deficiency, but still good enough to support, to offer support. And classically, this may be perhaps if you knock out a Morse implant and then you have still fairly decent proximal femur and you can fix in quite nicely maybe a primary stem. The problem always comes in type 3 onwards, type 3A, type 3B, type 4. And that's where you get increasing bone loss, destroying the proximal femur, the metaphysis, such that you cannot support a proximally coated stem. But the deciding factor is, do you have an intact isthmus to hold the reconstruction stem? And between type A and type B would be whether you have at least 4 centimeters of intact femoral isthmus to secure your distal fixation. And by the time we reach type 4, of course, the whole femur is basically patulous. So we had the good fortune of having Paprosky run a course with us 2 years back, and we asked him, why 4 centimeters? So it was from his studies using the monoblock full coat scratch fit solution type implants then, and he said that from his studies he found that if he had at least 4 centimeters of implant isthmus intact, he had very good initial stability, scratch fit, with excellent long-term survivorship. And there are also biomechanics studies to show that if you have at least 4 centimeters of intact diaphyseal bone, you can resist the torsional forces for mechanical stability using these scratch fit monoblock implants. So I was asked to perhaps show some cases how we choose the implants. Paprosky type 2, metaphyseal bone loss, but the metaphysis still supportive and the diaphysis definitely intact. So in a case like this, where the major problem is that you're trying to revise the acetabulum and the proximal femur still is fairly good, you could easily revise this with perhaps like a Corel type primary implant, but allowing for hydroxyapatite coating even distally down the entire stem. Another case, Paprosky 2, where the proximal femur, the cement mantle is still fairly intact in a low-demand elderly patient, and again the thing here is trying to get access to revise the acetabulum. And you could do things like tap-in, tap-out techniques with cement in cement revisions. And these are usually not a problem. And it's been shown to work well. Now we come to the type 3s. And here in the case, it is a type 3A because your isthmus is intact, the diaphysis, where you're going to secure distally. Seems fairly well preserved, at least 4 centimeters worth. Most of the destruction is in the proximal femur, where the osteolysis caused by the wear-generated debris causing the ballooned-out lesions are. So you could just bypass that and go for distal fixation distally. And this, in the old days, we were very happy with the solutions type stems, scratch fit, fully coated down the diaphysis. And then, of course, proximally, once you've gotten rid of that debris-generating machinery, often there's some healing of bone. And this extensive porous-coated implants, this monoblock scratch fit type implants, allowing us to bypass the weak or absent proximal bone, works very well. And Charlie Ng here has written up way back, showing 10-year survivorship in the results of 90%, even in Popowski trees, type trees. Now you notice I didn't talk very much about cemented revisions, but there are proponents of cemented revisions. But in a way, a lot of times our thoughts are colored by the fact that when we knock out the old revision implant and scratch out all the membrane with the fibrous tissue and all, we're left with a patulous proximal femur and a sclerotic cortical tube. And this old paper by Dome and Castillo shows that there's almost 80% reduction in the bone cement interface shear strength when we tried after one revision, and by the time you do a second time, it's even worse because you really don't have that bone for that cancellous bone for you to interlock your grouting cement into the cortex. All you have is a sclerotic tube. So because of this, and because of the desire that we're hoping for perhaps biological ingrowth and healing proximally, the tendency is to tend to use cementless stems. Now this is a Popowski 3B. By the time you reach a 3B, obviously you do not see the decent intact isthmus, and you start worrying, can I get good initial fixation? And in this type of scenarios, nowadays, we are more keen to use tapered titanium fluted stems. And the reason is that you could get the splines to give you the rotational stability and the taper to give you the axial stability that you want. And these have proven themselves to work pretty well, especially if you do them in a modular manner so that you are not constrained by a monoblock implant. You can go for initial fixation distally and then build upon that initial fixation using a proximal body proximally. So there are many variants of this. They come in scratch fit types, cylinder types. They come in modular fluted types, depending on the surgeon's choice. End of the day, the type 4s, by the time you reach type 4s, is really a tough call. And you really have, sometimes the philosophy would be, perhaps, to go to a short stem. And here you could consider things like impaction grafting, where instead of trying to go longer and longer down the canal, because there's really nothing to support you distally, maybe you go short, plug the femur proximally, fill it with impaction graft and cement in a short stem, and allow for some biologic restoration. A technique that is difficult to do, and for people who without the support of a bone bank, sometimes not so easy. And then, of course, you consider things like mega prostheses, tumor-type reconstruction prostheses. So let me summarize the classification. The type 1s, never a problem. The type 2s, also not a problem. And type 3s, when you think type 3s, you decide, do you have a 3A or a 3B? If a 3A, you could always get distal fixation quite reliably using a long stem distal coat implant like a full coat solution type or Wagner monoblock. By the time you take a 3B, that's what you start thinking, titanium spline tapered stems with a modular type to allow you to get distal fixation independently of your proximal version length tension. And then by the time you reach type 4, you start thinking, this is the one I sent to my best friend. Thank you.
Thanks.